Okay, guys, I've got your calendar. In case any of your classmates start texting or calling you after class, it is on Angel as well. Okay? It's front and back. So what we're going to do today is we're going to continue on and finish up chapter 22. We're going to do 23, 24 today as well. You'll notice at the top I have class a week from 8 a.m. to 12, or excuse me, 11, and then 12 to 2. That we may not have to be in here that long. Okay, it just depends on how long it takes us to get through the material. Okay, and that's for each day. Okay,
Starting when?
today. Hopefully it won't take that long, but I put that in there just as a heads up, just in case, because we really want to finish this cardiovascular on time and really stick to the timeline on this calendar so that we can have time to pre-test y'all on the previously covered material in this course, okay? And I can find out, see what you're lacking, see what we need to do, and that way I can build a review plan for those 3 days that say review, okay? Then your final will be the previously covered material and just a very few questions on cardiovascular, okay? That sound like a plan to everybody?
For tomorrow, it says exam 4. What about the ones that are going to Evans?
You'll have to make it up. I'll just have to schedule them another day.
And what's that over?
That's going to be over chapters 22, 23, 24.
Okay.
There's a lot of chapters to cardiovascular, so I broke them down.
Okay.
Thank you.
All right. Yes, ma'am?
So, the only clinical we are going to do is Evans.
Right. Your clinical hours, I already had extra clinical hours scheduled for spring semester. Any hours that you were lacking this semester that you did not complete, I'm just going to add them on for spring, okay? You're really not missing out on anything, because you're going to be doing a lot more variety of clinicals next semester. Okay?
When should we make up the test for Evans? We come.
Probably Thursday, after class. Or maybe Wednesday after class. Would that be better?
Yeah, that would work better Wednesday after class.
That'll work Wednesday after class. Okay, so let's finish up. I think this is pretty much where we left off with chapter 22. It's the diagnostic test. We're going to talk a little bit about those. We get more into diagnostic tests and what we're specifically testing for and looking at when we start talking more about our diseases and disorders. Okay? We do serum enzymes whenever there's damage to cardiac muscle. There are enzymes that will be elevated in the blood. Of course, everybody knows, typically we like to check a patient's cholesterol and their lipid levels. We can do x-rays. Your typical standard x-ray is not going to tell us a whole lot about the cardiovascular system. Typically, what we like to do with patients to measure heart function, we can look at the valves and how they function, how well it's what we call the term perfusing the patient, is an echocardiogram. And that's just an ultrasound. They place the wand over the heart and look at it. They can also do what is that? My mind just went blank. TEE, transesophageal echocardiogram. They actually have a wand that they actually put down the patient's throat through the esophagus and can visualize the heart there. It gives them a little bit better picture than going through the chest wall. Some other things, of course, they see done are cardiac catheterizations to check the coronary arteries, to see if there's any blockages, any narrowings, scarring. We can also do angiograms that check blood flow in veins and arteries. And these are usually, cardiac catheterization is going to be done by a cardiovascular doctor. The other ones are typically done by a radiologist. The echocardiograms are usually read by your cardiologist. MRIs, with this, we can look at the cardiac anatomy. It also tells us how it's functioning, the blood flow. It's really not that done that often because it is very expensive for MRIs, and the echocardiogram basically does the same thing and is cheaper. The electrocardiography, we can do these, that's the ECG, we can do these patients that maybe are having some issues, some arrhythmias, they may complain and say, I feel like my heart is palpating periodically. They may just go home with what we call a Holter monitor. That's a heart monitor that's 5 leads typically, and it just monitors and records the patient's ECG over a 24-hour period. And then a cardiologist reads the results. We have ambulatory, that's usually telemetry monitors that I talked about last week. The patient has them in the pocket of their gown or hanging around their neck. They're not strapped to that bedside monitor. Some other things we can do are what we call stress tests. This can be where the patient's hooked up to a heart monitor and they're made to walk and exercise on a treadmill. Depending on the patient's capability, their mobility, they may even get up to a jog, and they can make the treadmill go at an incline to make it more of an effort and a workload, and just see if they have any arrhythmias that are stress-induced. Any questions so far? We can do drug-induced stress test. This is going to show patients that may have some compromised blood flow. If they already have a coronary artery disease, and typically what we use is adenosine or percentin that's injected, and then they're scanned in radiology. This is typically done for patients that may not have good mobility, that are not able to, do a brisk walk or jog on that treadmill. And then, of course, the cardiac catheterization. It's really neat nowadays. Used to, they had to go through the femoral artery, and then afterwards, the patient had to be laying flat for 8 hours because you didn't want to do anything to dislodge the blood clot, because that's a really big artery, right? Okay. Now, they can go through the wrist. And so the patient's recovery time is almost nil, and they don't have to lay flat for 8 hours. They don't have to be non-ambulatory, not moving around for 8 hours, which is really good. Coronary arteriography. This also looks at blockages. And just like the cardiac cath, we're just going to monitor any vascular accesses and make sure there's no bleeding. And angiocardiography is going to tell us the size and the shape of the chambers in the heart. It looks at the coronary arteries as well. And it can tell if a patient has any congenital abnormalities. Aortography, that's actually looking at the aorta itself. It lets us know if there's any aneurysms. Y'all know what an aneurysm is? It's that weakening in the wall of the vessel. That's very important to diagnose. Patients that usually are diagnosed with aortic aneurysms don't necessarily immediately have to have surgery. It's going to depend on the size of the aneurysm. But they are monitored periodically to make sure it's not getting larger. Because as it gets larger, then the wall of the vessel gets thinner, and it's at a higher risk to rupture. If that ever ruptures, the patient needs to be in a hospital where they can do open heart surgery immediately, because they're going to have to crack the chest to fix it. If they have to travel 30 minutes to get somewhere to have that done, they'll probably be dead by the time they get there. angiography. This looks for occlusive arterial disease, and we're typically dealing with the legs here. Patients that have peripheral arterial disease in their legs, not good blood flow. Okay. Any questions on any of that? No? All right. We can go on to chapter 23.
Ms. Collins, is 22 gonna be on our Angel, chapter 22, PowerPoint?
I'll put it on there. It's not up there?
Mhm.
Okay, I'll put it up. Make myself the next I don't forget it. Yes, ma'am.
Before you go, that's a good point. I had made a note that I wanted to kind of share with you guys. The other day when I was in here and observing, I noticed that several of classmates, not sure if it was you in particular or not, but got very worried about the PowerPoint being different than the previous one that was posted. But what I found interesting is when I was walking around in the room, out of the group of 23, there was only about 5 of you that had the PowerPoint in front of you, and that you guys were spending a lot of time going through and highlighting in your textbook rather than looking at what the PowerPoint was and or that was in front of you. And I know that you're getting frustrated and you feel like things are not matching up. I would just caution you that as part of good note-taking and active listening is that if you have that in front of you, that instead of spending the time and highlighting in your textbook, that you actually are using or making notes on your PowerPoint to the slides to the side of it. Because if you're reading, that reading is not going to match up with exactly the screen that is on there. Does that make sense? Okay.
Yeah, we didn't have
we
it
didn't
on
have
our
it
22 PowerPoint, that was why we were trying to follow along, because it wasn't posted.
From last week?
Yes,
Yeah.
ma'am.
But then that's what I thought you guys went to the library and
Yeah, we
made.
did,
Yeah,
and
we
then we
22
still didn't
wasn't
have
posted.
22 on those that we printed,
Okay.
yeah.
So that's why we were doing that,
Yeah,
because we didn't have the PowerPoint.
We printed on those, we got in
For
here. and we
22.
still
But
wanted
that
to
makes
have
sense.
PowerPoint.
I was like, what are y'all doing in here? No wonder we're behind and we're all like trying to figure it out. And I was scratching my head. I was like, they were so adamant about that PowerPoint. And then they're in the book and not looking at the PowerPoint. So you're still missing 22.
Yes, ma'am, she's gonna put
That's
it
what
up
they were
there.
just telling me. I made a note to get it posted.
Okay.
All right, so now we're going to look at some infectious and inflammatory disorders that involve the heart and your blood vessels. Okay. There we go. All right. If y'all don't mind, I'm going to sit down for a little bit, okay? First thing we're going to look at is rheumatic fever. Typically, you see this in children. You don't really encounter it in adults. On occasion, and rarely, we do see it in young adults, like in their early 20s, late teens, but most of the time, if it occurs, you see it in children. It is basically, the rheumatic fever is caused by strep A infection. That's why it's very important when children have strep throat. Even though they finish the course of the antibiotic, a lot of times nowadays, the protocol is the pediatrician will have them follow up for another strep test to make sure they got rid of the strep infection. Because if it's left untreated, they can develop rheumatic fever from that. Okay? Your rheumatic carditis is actually, once again, it's the strep A, and it occurs because of the rheumatic fever. But what has happened with the carditis is the rheumatic fever has caused an inflammation. It's actually irritated the heart. The patients are actually going to present, their symptoms are going to be, they're going to have a mild fever. They're not necessarily going to run a really high fever with this. Their heart rate's going to be up. They may or may not have an abnormal rhythm, like it possibly could be irregular and not irregular. What's really indicative of rheumatic fever is the red rash that's on just the trunk of the body. You don't really see it on the arms or the legs, it's on the trunk. Okay? It's going to appear quickly and it's going to disappear quickly. Okay? And when it disappears, there'll be some irregular circles that can be noted on the trunk of the body. It will also can cause some of their joints, like elbows, knees, to be red, inflamed. They're going to be very painful, like not even a sheet. They don't even want a sheet touching the joints. They're just so painful. Okay. They may develop a murmur, a cardiac murmur, because of this, because it actually could damage either the mitral or tricuspid valves. So we also need to make sure we assess and listen for any murmurs. It can cause also a cardiac friction rub. And if you want to know what a cardiac friction rub is, take your hair, rub it between your fingers. And when you listen over the heart and you hear that crackling, that rough sound, that's an indication that the membranes around the heart are inflamed, they're irritated, and it's causing them to rub together. Everybody with me? So what tests do we do? Well, we can do an sedimentation rate. We can do, of course, ECG tracings. We're also going to run a C-reactive protein. The ESR, the sedimentation rate, and the C-reactive protein are blood work. We simply draw and run. Probably also going to do a CBC because we want to check our white blood cell counts. And treatment is antibiotics, preferably penicillin. Excuse me. If we have to throw in some big guns, we may go with Zithromax or vancomycin. If the patient has constrictive pericarditis that's occurred as a complication of the rheumatic fever, then they may actually have to go in surgically and release some of that tissue. If there's damage to heart valve, they may have to go in and do a heart valve replacement. We want to make sure our patients stay healthy. We will put them on aspirin. This is prophylactically, okay, just like any cardiac patient. We like to give aspirin to prophylactically. So how are you going to take care of patients? Well, you're going to give the medications the doctor's order, right? Continuously assess your patient. They're children, so they're going to need a lot of what? Diversion therapy. They're going to be bored. They're going to be restless. They need color books, crayons, video games, just whatever you can do to keep their attention diverted and not complaining and up. These patients are going to need to be on bed rest initially. Okay, so this is why your diversional therapy comes in. It's really important. How many people know a kid that's going to stay in the bed, that is going to stay in the bed 24/7 for 3 or 4 days? Not many. When they're discharged and sent home, they may still be on an antibiotic by mouth prophylactically, just to prevent any secondary infections occurring while they're recuperating.
What is ESR?
Sedimentation rate. I can't remember what the E stands for. I just said rate.
I have a question.
Yes, ma'am.
The book monitoring that we're looking at talking about, gerontologic, can an elderly person have, rheumatic carditis?
They can, but you just don't see it that often.
Okay, because I thought that it said that if, at some point when they were younger, that they had stress A, and then, I don't know, later on in life,
They-
you could end up with a rheumatic carditis. And I may have read it wrong.
I have never seen rheumatic carditis in an elderly person. usually you see it, the patient's gonna develop rheumatic fever. They're not gonna have, if they develop rheumatic carditis, it's not gonna occur right then in the initial infection and diagnostic process. Hopefully you catch it before they develop rheumatic carditis. It's very rare to really, nowadays with testing, drug and antibiotics, that we have to see it develop rheumatic carditis. Does that help you? Now, infected endocarditis. This is usually typically seen in young to middle-aged adults. It's actually an infection that is called an inflammation of the layers in the heart tissue. Okay? They believe it is an autoimmune response. And usually an autoimmune response is triggered like by a viral infection or something. We see that a lot with our autoimmune disorders. It can also be caused by your streptococcus and your staphylococcus and even a fungal infection. If a patient has had prolonged IV therapy, if they've had a pacemaker put in, they've had a cardiac catheterization, or even a Foley catheter insertion, this could put them at risk of it, contracting infective endocarditis. These patients are going to have fever, they're going to have chills, they're going to be hurting and achy all over, and even in their joints. You may see some little splinter hemorrhaging, like capillaries rupturing, especially in the lower extremities. They can develop some petechiae. They will develop a heart murmur. These patients usually are going to have significant heart damage, and it is not unusual to see these patients needing a heart transplant. They will develop what we call, because of the endocarditis, they will develop what we call cardiomyopathy.
Why would a Foley catheter cause?
Because you're introducing the bacteria. These patients are going to be anemic. They're going to have leukocytosis. We're going to have to do blood cultures because we want to rule out a systemic infection, okay, and see what grows out and make sure our antibiotic is going to cover it. They'll have an echo done, and they will be on a continuous bedside monitor, ECG monitor. These patients will be in ICU initially. These patients are going to be put on high doses antibiotics, very strong antibiotics like vancomycin, probably. They need to be on bed rest. They're not going to be able to tolerate a lot of activity. If they develop the heart murmur, they can go in and do a valve replacement, but it's going to depend on how much damage has already been done to the entire heart. If they're going to possibly be a candidate for a heart transplant, then they're not going to go in and do a valve replacement. They're going to try to wait until a heart becomes available. These patients, like I said, are going to have an activity intolerance. So you want to limit the activity. You want to make sure you organize your nursing care. Okay? You don't want to go in there and do their bath, and then go back an hour later and do the bed, and go back an hour later and do then try to coordinate your care so you can get everything done in about 30 minutes and then leave the patient alone for 2 or 3 hours so they can rest in between. And of course, we're going to be watching all the vital signs. Like I said, they're going to be a continuous bedside monitor in ICU. Now we have myocarditis. So we have what? This is affecting what? The actual muscle. This is, once again, you're looking, it could be a viral infection, it could be caused by bacterial or even a fungal infection. Okay. The one that makes this a little bit different is that it can also be caused by parasitic infection. Okay. But you typically are not going to see that except maybe in underdeveloped countries. It is caused by the Coxsackie virus, A and B. It can be caused by influenza, A and B. Patients that have had recent measles, mumps, or any exposure to the Epstein-Barr virus. These patients will complain of sharp stabbing pains. They're always going to have the symptoms of having an MI. Okay. When they sit up, it helps relieve the pain. What's going to make it indicative of an MI is they're going to be running a low-grade fever, and you possibly will hear an S3 gallop if you listen to their lung sound, their heart sound. And that's really going to be kind of indicative there. Because initially when they come in through the ER, we go, holy crap, they're having an MI. And then we get in there and start assessing their vital signs and they've got a low-grade temp, and we start thinking, maybe not. Okay. We're still going to screen them and run them as if they're having an MI, but then we're also going to start looking at possibly myocarditis as well. These patients, we're going to run a WBC because we want to check their white blood cells. So probably going to do a CBC. So it checks red blood cells, hemoglobin, hematocrit. It's going to check everything for us. The big thing we want to do when we do a CBC, we want to make sure it's a CBC with a diff. And that's going to tell us which white blood cells are elevated or low, so we know more of what type of infection is going on, whether it's viral, bacterial, those types of things. Okay. Of course, they're going to have the C-reactive proteins. They're going to have ECGs. We're going to do chest x-rays. Probably going to send them for an echo. Radionucleotide biopsies, that's going to be done at a later point. Radionucleotide is basically a nuclear medicine state. They inject them with a radioactive iodine and then x-ray them and watch them. These patients need to be on bed rest. They're going to be monitored at the bedside. They're going to be on a low sodium diet. They're going to be given some cardiac drugs. More than likely, probably digoxin, getting a loading dose and then a daily dose. And typically, dig is going to be started as IV. So we give an IV initially. And then when we get them to a therapeutic blood level, then the doctor will put them on medication. So we're going to monitor our patients' cardiopulmonary status because they are going to be short of breath. They can develop some crackles. We're going to watch their intake and output. We're going to do daily weights because we want to make sure we're not getting fluid overload issue. And of course, we're going to do continuous O2 sats with these patients. Any questions so far?
Are the people that are susceptible to this already immunocompromised somehow?
Sometimes they are, yes. Some are. Typically, you're going to see those patients, especially if it's caused by the Staph virus or the influenza, it's usually those patients are going to have already an compromised system, either because of other chronic illnesses going on, like diabetics, things like that. They're going to be more prone to it. That's why it's important with our patients that have chronic diseases, they get those vaccines every year. Cardiomyopathy. This is, there's three different types. There's dilated, there's hypertrophic, and there's restricted. Basically, what happens with cardiomyopathy is the heart muscle is not able to contract as well. So therefore, it's not going to be pumping very well. Okay, it's not as efficient. With your dilated cardiomyopathy, you're going to find these patients are very short of breath with activity. Even when lying down, so they're going to need to be in one position, do you think? Half hours, yes. So they're going to be on bed rest. You will notice edema in the lower extremities, and the patient may complain of palpitations, however you want to pronounce it. Okay. Hypertrophic cardiomyopathy, these patients will complain of syncope, they're gonna complain of chest pain, or they could be asymptomatic and not even know it, that they have it. Restrictive cardiomyopathy, these patients will have exertional shortness of breath. They'll have dependent edema in the legs. That means when they're sitting up and their legs are hanging, okay, they're gonna develop edema, but once we get them up and elevated, the edema will kind of minimize and possibly even totally go away. Okay. They can also develop ascites and hepatomegaly with this. Y'all know what ascites is? It's a fluid buildup in the abdomen, which is usually going to be due to the hepatomegaly, enlargement of the liver. You will see patients that have liver cancer, hepatitis C, alcohol-induced hepatitis, anything like that going on in the liver that causes hepatomegaly in the liver. The ascites is always going to be a complication of anything going on in the liver like that. So, once again, pretty much the same type of test we do with any other heart issues. They will be on continuous bedside monitoring in the unit. What makes us a little bit different, because of the edema issues, they are going to be possibly on diuretics. Because the heart's lost the contractility, it's not pumping as well, we're going to put them on digoxin. It slows the heart rate and increases the contractility. That's what DIG does. So you'll be monitoring DIG levels as well. We don't want them to get toxic on it. They may develop hypertension because of this, so they may have to be on antihypertensive medications. If they develop dysrhythmias, we'll have them on antidysrhythmic medications. They're going to be on anticoagulants because they're going to be on bed rest. And because the heart, anytime, any condition, the heart does not pump effectively, they're at a higher risk of developing blood clots, okay? Because of that stasis in the bottom of the ventricles, okay? We'll give them corticosteroids. This helps reduce that systemic inflammatory response. Hopefully it's going to help with that. And they are also going to be on a sodium restriction, okay, because of the fluid issues. The patients may need a pacemaker or a defibrillator implanted. We can go in and do a ventriculomyomectomy. I have to look at that word to pronounce it. That's a mouthful. I've never seen that done. Not sure what percentage of patients have to have that done. I've never seen it. Another issue too, depending on how much damage is done to the heart, they may also need heart transplant. You can put a pacemaker in, but if there's not much muscle function left, pacemaker's not going to do a whole lot for them. Any questions?
No. I do have a question. I was gonna go back and look at it, but what's the difference in an ECG and an echocardiogram?
The ECG is the patient's hooked up to the heart monitor. That's your heart monitor at the bedside, okay? The echocardiogram is an ultrasound. That's where they look at the valves, they can look at the chambers of the heart, they can actually see the blood flow through the heart. They'll even measure what we call the ejection fraction, the left ventricular function, and tell us what percentage it's actually pumping. We see this a lot with patients that have compromised cardiac functions. We see it. We do it a lot in patients with heart failure because that's an issue with them, is heart function. Okay. Did that help you?
Yes, thank you.
The next thing we're going to look at is your pericarditis. This is an actual inflammation of the pericardium. The pericardium is where? Around the heart, exactly. So when you're having this is usually because of another issue. It's a complication. It can be, it doesn't necessarily have to be the endocarditis or myocarditis infection. If patients had blunt force trauma to the chest, like not wearing their seatbelt, and before we had airbags, you'd see a lot of times the patient's chest hit the steering wheel. They would develop pericarditis for that, or we would actually admit them if they had steering wheel bruising on their chest when they come in. They would actually be put in ICU initially to monitor for the development of pericarditis. We don't see it a whole lot anymore from the MVA victims because of the airbags now. Patients that have had myocardial infarction, a heart attack, they can develop pericarditis as a result. If they've had any type of open heart surgery, they can develop pericarditis as a complication. Pericarditis can actually develop into a cardiac tamponade. This is where, because there's so much inflammation, it is actually compressing the heart muscle, and the heart muscle is not able to contract and release like it should. So when you see these patients, they may have a fever, depending on the cause. If it's an infection, if it's a complication of an infection, then they'll have a fever. They'll complain of malaise, that's that general weakness, fatigue, don't feel good kind of feeling. They may complain of some heaviness in their chest. They may have some precordial pain. And they'll tell you that taking a deep breath or moving around makes the pain worse. If they sit upright, like straight upright at a 90-degree angle, or even leaning forward, it kind of helps a little bit with that pain. These patients typically, if they develop pericarditis, when you listen to their heart sounds, you'll hear that friction rub. And if it's not treated and we're not monitoring our patients closely, they can develop serious, severe hypotension from it. Why, do you think? Right, the heart can't beat, it can't contract with enough force. And we know that our blood pressure is telling us what? How much vascular resistance we have and how well our heart is actually pumping. When you look at these patients at their ECG tracings, you're going to notice ST segment depression. Okay. Or excuse me, elevation, I'm sorry. It's going to look like they've had a heart attack. And basically what you're going to see is, let me see if I can do this on the screen. Well, it's not going to let me do it. Now it's doing it. Let me erase that. So basically what you're going to see, if you go here, you've got your wave, you've got your little P wave. This ain't going to be real pretty, y'all, okay? And you got your QRS, and then you come here, and their ST segments are going to be elevated, where it should be little, like this P wave, or almost non-existent. That makes sense? Now that's not indicative, and that does not tell me, oh, this patient's got ST elevation, so they had pericarditis. We see that also in patients that have MIs. Okay? It's not, like I said, indicative. That help give y'all a visual? All right. These patients are going to be getting, of course, we want to see what their WBCs look like. Make sure, it's not related to an infection. We're going to do their sedimentation rates, chest x-rays. They're going to be in ICU. They're going to be on continuous bedside monitor. Continuous O2 sat. So what's the treatment for anything cardiac, y'all? What are we gonna be doing?
Aspirin, morphine, oxygen, nitro, and
Continuous bedside monitoring, continuous O2 stats. Yes. So, that's basically, these patients are gonna have these cardiac issues. You know they're gonna be in ICU. You know they're gonna be in continuous monitors, continuous O2 stats, and we're gonna treat their symptoms. We're gonna try to save as much heart function as we can. That is our goal with anything cardiac. Depending on the cause, we're gonna look at rest and of course pain medicine. Our pain medicine of choice with cardiac patients is morphine because it dilates the veins and arteries and increases blood flow. If they're, of course, if they have a fever, running fever, we're gonna give them, some ibuprofen or Tylenol. They may need, depending on the cause, some NSAIDs, or they may even start them on corticosteroid therapy, IV, and then maybe progress, then change them over once it starts getting better to steroid or maybe just NSAIDs. If it is severe enough of a problem, then we'll go in and do a pericardiocentesis. Y'all remember what thoracentesis is? So what's the pericardiocentesis going to be? Space between the layers, pericardium.
Pericardial windows, what's that?
That's your if they're doing a window, that's going to be this, the pericardiostomy or pericardioectomy. Okay. Those are where they're making the windows. They can also do a decortication. They actually just go in and detach it from the actual heart muscle. Besides monitoring their pain, listening to their heart sounds, you want to also monitor patients for JVD. What does that stand for?
Jugular vein distension.
Huh?
Jugular vein distension.
Yes, jugular vein distension. Yes. If they start developing some JVD, you also want to monitor and see if they are coughing up anything. If these patients start having that pink frothy sputum, what are they going to be developing? Pulmonary edema. It's also going to increase their shortness of breath. It's going to increase their anxiety. It's going to affect their pulmonary function. Y'all want to take a break here? Got in for a few more minutes, about 15 more minutes? Okay. All right, so let's look at our blood vessels. Some issues we can have here, thrombophlebitis, that's basically what? It's irritated, it's been injured, most of the time it's going to be caused by clot. Patients are going to, typically we see this most commonly in the lower legs, like from the knee down. It's going to be typically in the calf of the leg. They'll complain about some calf pain. The Homan sign, that's where you take the foot and flex it back towards the knee and let go, and they'll complain of severe pain when you do that, but that we don't do that anymore because it's really not indicative. We just don't really do that anymore. I'm surprised it's even in there because we just don't bother with that anymore. The only time we worry about Homan sign are any pregnant ladies that are on MAG drips. There may be some heat, some redness. There might be some swelling to that calf, to the calf. You'll notice when you check the capillary refill in their toenails that it's going to be less than 2 seconds. They can even develop a fever with this. And of course, they may be feel tight because it's an infection. They have that malaise and that fatigue. Okay, and they may not have much of an appetite.
So what would be the, to indicate this would just be mainly the discomfort in the extremity and calf pain?
Yeah, that's gonna be that is gonna be our indicative, the calf pain, the heat, the swelling is really indicative of it. The patients are gonna go down and have x-rays done for a definitive diagnosis.
But it's more common for people with any type of heart issues?
Not necessarily. It can be. Typically, the clots are gonna develop in the legs, in your extremities first. What we worry about with thrombophlebitis is that clot moving to the lungs or the heart. Then you've got a pulmonary embolus, or your patient's gonna have a heart attack because of it. They can even move to the brain and cause a stroke. So they're patients that have decreased circulation in their lower extremities are going to be prone to developing thrombophlebitis. Patients that are on bed rest, they're post-operative, they're at increased risk of developing thrombophlebitis because they're what? Well, they've had surgery, so the body's doing what? Clotting. Yeah. They're on bed rest, they're not moving around, so what's happening in that blood in the lower extremities? It's not returning and moving, it's just kind of settling. That's why we have the TED hose, that's why we use what we call the SCD, sequential compression device, that we wrap around the calves and they pump and release, because it's mimicking the muscle movement, it's getting that and preventing that venous stasis in the legs. Typically, we call this deep vein thrombotic, DVTs. We can go in and do an ultrasound, a Doppler ultrasound. That's usually just checking blood flow. Like I talked last week, you want to check blood flow. You want to start where? The pedal pulse, on top of the foot, okay, and then work your way up. They will take them to X-ray and have an IPG or either a venography done. Okay, check blood flow. And this is in the vein, it's not in the artery. Okay, it's in the veins. We want the patient to move around. Used to, they were like on strict bed rest. You know, you didn't even want them to go into the bathroom. Not even a bedside commode. They had to stay in the bed. That used to be typical treatment. They used to put these patients in ICU when they were on bed, strict bed rest, and not move. Now they want them to move around some. Okay. Usually they're on bed rest with bathroom privileges, so they can get up and go to the bathroom. We don't necessarily, want them to walk 2 miles, around, make laps around the hospital or anything. But they can get up and go to the bathroom. We can do compression bandages. There's really not been any proven research that says that helps. It may relieve some of the pain for the patient, just kind of like a support there. Of course, they're going to be on heparin drips initially. Continuous heparin drip initially. And they'll be started on a sub-Q anticoagulant. And they will probably go home with a sub-Q anticoagulant to take for a short period of time. Used to, we would simply put them on a heparin drip. Once we kind of got them therapeutic and it was starting to resolve, we'd start up on heparin by mouth and do blood levels every day to make sure human levels are therapeutic. But we have a lot of other stuff out there that we don't have to do blood levels with anymore. Makes it a lot easier on the patient. They don't have to be stuck every day. Wet packs were really good. They help kind of relieve the pain and symptoms. Depending on how severe the clot is, if there's a clot in there that has actually totally occluded that vein, they can go in and strip it to get rid of it. Usually those are the vascular surgeons. They'll go in and do that type of stuff. You want to make sure and question the patient, have they had blood clots in the past? If they've had blood clots in the past, they're gonna be more prone to developing blood clots in the future. You need to go over risk factors and teach your patient what are their risk factors for developing these DVTs. What's their lifestyle? You know, if they're sitting around their couch potatoes, they already diabetic with having, you know, peripheral circulatory issues, they're gonna be at risk. Patients that are morbidly obese are gonna be at higher risk of developing DVTs because why? They're sedentary. Excuse me, y'all. Women that are on contraceptives are gonna be at risk for developing blood clots. That's a side effect of contraceptive use.
For just, the pill or like IUDs or all of it?
Hormone contraceptive. What?
Well, that would be the only thing.
Yeah, the
that is
only
in-
contraceptive that doesn't have hormones is copper.
That'd be a Miss Howard question.
I think they do have pill options that they have on there.
Yeah, low E pills.
Yeah, that's why you see nowadays when the doctors do start women on contraceptives, they start at the lowest possible dose. So it kind of helps eliminate some of that risk. What's important with these patients is monitor them. If they develop sudden chest pain or dyspnea, that means that blood clot has moved. It's either gone through, it's in a coronary artery that's causing the chest pain because it's blocking oxygenation and blood flow. If they start developing the severe shortness of breath, that means it's moved to the lungs, and then we have a pulmonary embolus. So it's very important to monitor them for those two complications. Thromboanginitis obliterans, also called Buerger's disease, not Booger's disease.
I thought it said burgers.